Good morning, everyone, at least on the East Coast. My name is Ken Jennings. Welcome to episode 2. Today we'll be delving into a very controversial topic, one that specifically came up in the news yesterday, but has been on a lot of people's minds for quite a while now, is the topic of transgender kids and whether or not they should have access to any gender affirming care, what that means, and how to actually address it. So if you've never met me before, if I'm a new face to you or a new name to you, my name is Ken Jennings. You'll also see me as Ken Jennings KF. I originated off the Kiwi Farms in a shit show of a thread due to a personality disorder and identification, personal-ish observation diagnosis thingy I made. And now I have made my way into doing this on my own streams. I've had the pleasure of being on other people's streams, but I am wanting to do my own thing to some degree. I had the pleasure of having a guest or two on a previous stream of mine, and I'm looking forward to having future guests on my stream as well. Not just big names and people, if any of those would want to join me, but I also want everyday people on here as well. Uh, Everyone has a story to tell. Everyone's life is different. Everyone's experience is different. You bring something special and unique to the table that not everyone is going to realize out the gate. You may not even realize it. What's important is to be comfortable with yourself in opening up about it. Like I tell all my clients the first time I meet them, walking through the door into my office, making the phone call to schedule the appointment. They're all acts that make you vulnerable to some degree because at a core level, it breaks down to I'm asking for help. And not everyone's able to do that easily. So, my goal with this is to not only provide information based on my background as a therapist and a counselor and some other experiences and unique privileges I've had in life, being able to work within communities like the one I'm about to talk about, but be able to inform those around me and the people I also engage with how to deal with some of these similar topics and what they mean as a general rule and as a general thing for everybody. So, first off, I have a brand new microphone. As a personal aside, I bought a new microphone, somewhat expensive. I also have some fancy audio, those 12 by 12 foam thingies to help with any echoes I have in my my office and my home office. And I am still trying to perfect my own stream setup instead of using StreamYard, but part of me is lazy, and I'm probably just going to give up on that at the end of the day and just pay for the StreamYard monthly to get rid of the logo and the other features it gives me. Because I would like to spend more time focusing on creating the actual content instead of dicking around trying to perfect OBS settings. So, like I said, today's topic is transgender children in medical transition. So, what I'm going to do is pull up my screen for that one. What I did is I've created a PowerPoint to go over this topic. No fancy graphics, nothing flashy like that. But I do hope that going through this, you guys are able to get something from it and we're able to address what normally might not get addressed because it's such a controversial topic. So, we'll start with the expectations of this show today. I don't know how long it's going to go, but my goal is to at least get through all of the material before closing off the show today. I might be on a limited timeline and a budget for time today because I have shit I have to do around the house today. because it is my only day off during the week, except weekends. And even then, I'm busy doing other shit. But we're going to do three main things today with this. We're going to focus on the DSM and what the diagnostic criteria is for diagnosing gender dysphoria, both in adults and children, but primarily in children and adolescents. Second, we'll be talking briefly about the history of the standards of care, and then kind of really diving into the standards of care and what those are and what that means for transition related care for children and adolescents. And then onto the big, oh my God, everyone's losing their goddamn minds thing of Arkansas's HB1570, which they are calling the SAFE Act, which is Stop uh, Abuse or Protecting Children for Adolescents from Medical Experimentation, uh, is their idea for the meaning behind that, because it's the reasoning in the logic of passing the law, from my understanding, is they're viewing this type of treatment as medical experimentation. And so then that's why you'll see a lot of biased language, maybe in one direction versus the other, regarding this law. And you'll also see when we go through some of the definitions in the actual text of the law, whether or not they flow with definitions you might run across or terms you might run across in the DSM or the standards of care. So on to the next thing will be the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, also known as the DSM-5. It's the current edition. As I mentioned, we're going to briefly discuss the diagnostic criteria related to gender dysphoria. For those of you unfamiliar, briefly, gender dysphoria is basically an incongruence with your assigned gender or birth gender and your lived gender or experienced gender. So if you were, for example, assigned male at birth or assigned female at birth as your gender, and you are actually living in a gender opposite of that or somewhere in between, then you would most likely have symptoms of dysphoria, dysphoria being stress, discomfort, things along that nature. So what I'm going to do is move on to this. And as you'll see, I've turned PDF pages into PowerPoint slides because it was easier than taking screenshots and it came out more professional. So if some of the pages are like half off, like cut off, it was because A, I either removed unnecessary material, or B, it might have fucked up and I just missed it whenever I was importing everything. So we'll start off with the diagnostic criteria for gender dysphoria in children. So we will start up here around this area. So I'm going to be fancy and use the laser pointer and the highlighting features and drawing features. So gender dysphoria is a marked incongruence between one's experienced and expressed gender and assigned gender of at least 6 months in duration, as manifested by at least 6 of the following, one of which must be criterion A1. So the criterion will be marked in letters and then numbers. So this is A, so criterion A, and then 1. So for example, what this means is to get the diagnosis of gender dysphoria for a child, you have to meet the criteria A1 at least and have at least 6 of these in this area right here. And you'll also need criterion B, and you'll see why in a few seconds. So criterion A1, so we'll move on to the next one. So 1, a strong desire to be of the other gender or an insistence that one is the other gender or some alternative gender different from one's assigned gender. So this doesn't necessarily mean you want to be the exact opposite gender. There is the perception of gender being across the spectrum, depending on how you look at it. Just like people will also look at sexuality as not necessarily being, you're 100% straight or 100% gay. You will fall along a line somewhere. And I have the argument, I can argue no one is 100% straight or 100% gay, and I can prove it to you. So the next criterion for gender dysphoria in children, 2, in boys, for the assigned gender. So again, assigned gender being gender assigned at birth or during young childhood. A strong preference for cross-dressing or simulating female attire, or in girls for their assigned gender, a strong preference for wearing only typical masculine clothing and a strong resistance to the wearing of typical feminine clothing. Criterion A3, a strong preference for cross-gender roles in make-believe play or fantasy play. Criterion 4, a strong preference for the toys, games, or activities stereotypically used or engaged in by the other gender. So 3 and 4, stereotypical play for the opposite gender. For example, for girls, stereotypical play would be like playing with dolls, playing house, taking on feminine roles. So if you're a boy and you're engaging in that, seeking out that, and you prefer that strongly compared to typical masculine behaviors, that would be a marker for that criterion. The same thing for, not just in toys, in games, but in make believe play and fantasy. So as a child, you know, if you're doing, for example, playing house or playing those types of fantasy plays and those types of role plays as a child does, and you're taking on more feminine types of play, but you were born assigned as a boy or assigned as a male, then that would be likely a criterion you would get assigned. And you would likely meet that criterion when you're going through and getting a diagnosis of this. Again, remember, it also takes at least 6 months duration of these symptoms to be eligible for a diagnosis of this. So the next one, 5, a strong preference for playmates of the other gender. So if you're a boy, preferring to play with girls. If you're a girl, preferring to play with boys. Number 6, in boys, assigned gender, a strong rejection of typically masculine toys, games, and activities, and a strong avoidance of rough and tumble play. Or in girls, as assigned gender, a strong rejection of typically feminine toys, games, and activities. 7, a strong dislike of one's sexual anatomy. So you'll see this in typically not just with children, but you'll see it again in adults. People will have a dislike, not just, oh, I don't like my body because I don't like the size of, for example, my penis, or I don't like the way my labia looks, or I don't like the way my vagina looks, or any of that. That's not specifically that. It's the feeling of just, it doesn't feel right necessarily. It just doesn't fit. It feels wrong in a way. And that's one of the things you'll come across in relation to this, is you can feel wrong in your body. And it sounds kind of complicated, and I will agree that it is. I will do my best to simplify it, and I will do my best to check and answer questions along the way. Because I have PowerPoint set up a certain way, I may miss questions, but I'm trying to make sure I keep my comments open. So the next one, since we've gotten through all of criterion A, we're going to be moving on to criterion B, which will be right, where'd it go? Right here. So we're on criterion B now. Let me pick a different color because, oh my God, that looks awful. Let's do dark red. How about that? Perfect. We'll do that one. All right. So erase all the ink. Okay. So criterion B, the condition is associated with clinically significant distress or impairment in social, school, or other important areas of functioning. The key word for this will come down to clinically significant distress, right? So this right here, clinically significant distress. Sorry if my writing looks like shit. I'm trying to draw on a tiny ass laptop screen while also projecting to a larger screen. It's not necessarily working the way I want it to. So what you'll see right underneath criterion B is a specifier. What a specifier is a way to specify specifics relating to a disorder. For example, an adjustment disorder, you can specify if it's associated with depression or with anxiety, or say some other condition specified because of uh, a physiological condition, or it's associated with, it's due to some sort of drug use. There's a whole bunch of different specifiers you can come across in the DSM. But for this one, the specifier is with a disorder of sex development. So this would be a diagnosis of gender dysphoria specified with a disorder of sex development, meaning a congenital disorder uh, such as adrenal hyperplasia or androgen insensitivity syndrome, both of which can change your sex organs and secondary sex characteristics. And you, for example, with androgen insensitivity, it can impact the ability for your body to absorb or to relay and, androgen. And so you will not necessarily absorb it and your body doesn't recognize it. So you can not necessarily get the features you want. I don't remember off the top of my head who that normally presents with and how it works, but I have some familiarity with some of the other ones. And the other sex disorders are stuff like Turner syndrome, where you can have like different types of sex disorders. You'll see this in specifically political arguments on the topic of things like, well, you're either a male or a female. And then some of the people who will argue the point, you'll hear, well, there are people who are born with some of these different things, or they have ambiguous genitalia. With ambiguous genitalia, meaning you can't tell one way or the other what their genitals look like. They could be male, they could be female, or they can't be differentiated between. You used to This used to be kind of known as being, I can't remember the word, it's blanking off on me right now. Someone thinks of it, reminded me. But so as you'll see, as we go through this, there is a difference in the, oh, I can't do that apparently. Sorry. So as you'll see, there's a difference in some of the diagnostic criteria in children, as we talked about up here. And then there'll be a difference in the diagnosis of adults and adolescents down here. So give me 1 second. I need to step away for a brief moment. And I'm back. Sorry for the delay. Phone call from the old ball and chain, as they say. So going back to what I was discussing, and I see some comments here in the chat real quick I'll address before getting back into the presentation, is so far, most of these things don't seem out of the ordinary for children. One person commented, uh, yes and no. So there is a difference in what you'll see in the diagnosis, right? So just because a child or a person exhibits some of the behaviors is different from them exhibiting clinically significant behaviors or symptoms. So, for example, a boy or girl may try on boys or girls' clothes, uh, for a game or a play thing. They're not necessarily doing it as I'm wanting to do this because I really enjoy it. It may just be for the play of that moment. You would see something being clinically significant where in a significant majority of your play, that person will engage in mostly, for example, for boys, they will engage in mostly feminine roles in play. They will engage in mostly feminine clothing in dress up. They will take on stereotypically female roles in female characters in female fantasy play. So while some of it seems normal for boys and girls and kids in general, it comes down to what is beyond the normal limit, what's beyond the background, what's rising above background. Again, excuse me real quick, I'll be right back. All right, I'm back again. Sorry for the delay. Say I had to address another phone call. Say that is one of the downsides I might have to deal with occasionally doing streams. Is in the business I work in, is I do get the occasional call or text from clients that I have to deal with. I am doing my best to make sure I block off time to where my clients or people aren't calling me during this kind of stuff. So back on topic. So I know I was briefly mentioning the behaviors and things that are outside of the ordinary. So you have to do things that are, you have to recognize things that are just beyond the normal level of expectations, beyond the background, right? So the occasional play, the occasional trying on clothes, the occasional things like this. The, oh, I want to be a girl, I want to be a boy, you know, and it's not in just a playful way or uh, a growth period or a developmental period for a child where they may be more curious about the other gender or other sex's body, and so they find themselves interested in it and wanting to participate in that and be that person. It goes from that to being, it's distressing to be in your body, or it's distressing to have to know that you're not able to be the other gender, right? Or a gender other than your current one. So, and I'll go back and forth on that. I'm trying to use them properly, but interchangeably, I mean both. So, both your current gender and or other genders that are outside of your typical male female. Uh, I'm not going to get into the validity of any specific gender outside of that. You do you is my thing. So, when we get down to the criteria for adolescents and adults, it becomes a little different. So down here now is where we are. So with that, we come to the next diagnostics. So for criterion a marked incongruence between one's experienced / expressed gender and assigned gender of at least 6 months duration, as manifested by at least 2 of the following. So up here for children, there was 6. Down here for adults and adolescents, it's 2, right? So And another thing that you'll see the difference in is with children, you have to have criterion A1. You absolutely have to have it. It says this right here. Criterion A1 must be present to diagnose it in children. For adults and adolescents, not so much. You can diagnose it with just 2 of the following, with no specific of the nothing specific of the criterion listed. So criterion A1, so the next one, so that would be this one, would be a marked incongruence between one's experienced/expressed gender and primary and/or secondary sex characteristics, or in young adolescents, the anticipated secondary sex characteristics. So if you haven't reached puberty, or you are just starting puberty, your expected sex characteristics be secondary sex characteristics being breasts or penis growth due to puberty, or testes dropping and testes growth, pubic hair, even though that is existing across both, sexual activity in some way, not necessarily relating to the sex characteristics, but you'll see in adolescents and adults, there can sometimes be, and there used to be a diagnosis in previous versions of the DSM. I don't believe it's in the current one, but autogynephilia was a diagnosis you would see that was somewhat related to what is now known as gender dysphoria. It had a previous name under the old DSM, gender identity disorder. So GID was the acronym you would see. So if we move on to the next diagnostic characteristic, so back down to 2, a strong desire to be rid of one's primary and or secondary sex characteristics because of a marked incongruence with one's experienced or expressed gender, or in young adolescents, a desire to prevent the development of the anticipated secondary sex characteristics. So on to number 3, a strong desire for the primary and or secondary sex characteristics of the other gender. Number 4, a strong desire to be of the other gender or of some alternative gender different from one's assigned gender. So it doesn't necessarily have to be male or female. You can hit one of the ones in between, however your views on that may be. Number 5, a strong desire to be treated as the other gender or some alternative gender different from one's assigned gender. Number 6, a strong conviction that one has the typical feelings and reactions of the other gender or some alternative gender different from one's assigned gender. So moving on to the next slide, we have an 8th. I think we cut off a criterion maybe. So 8th, the condition is clinically significant distress or impairment in social, occupational, and other important areas of functioning. Briefly, I'm going to verify in my own DSM to make sure that criterion 7 wasn't missed and it's just being it was mistranslated or misaddressed whenever I did the PDF to PowerPoint. So I don't want it to come off incorrect. So, okay, so it misread this. This should actually be a B. So that number 8 should actually be a B. So this is criterion B up here. Yes, that's a horrible B. Let's just get rid of that. So criterion B being the condition is clinically significant distress or impairment in social, occupational, or other important areas of functioning. As we saw with the child one, disorders the development of sex. So again, the different sexual development disorders you can have, usually congenital, is the ones you'll see. And then you can also down here, because we're talking about adolescents and adults, specify if post-transition. God, I need to learn how to draw a little bit better on a tiny screen. So what the specifier of post-transition is the individual has transitioned to full-time living in the desired gender with or without legalization of the gender change. So getting it formally recognized. So getting your driver's license changed, getting your social security to reflect your gender change, getting other agencies to reflect it. So you can start full-time living in that gender, but still haven't been crossing the legal boundary with like a full legal name change, full legal documentation change. So they've not only full-time living it and has undergone or is preparing to have at least one cross-sex medical procedure or treatment regimen, namely regular cross-sex hormone treatment or gender reassignment surgery confirming the desired gender. Examples of this are a penectomy, the removal of the penis, a vaginoplasty, which is the creation of what is referred to as the 𝗦𝘂𝐻𝐬𝐬 in transgender women. So that's transgender males to females. So in a transgender woman, the 𝗦𝘂𝐻𝐻𝐬 is the creation of the vagina using usually either techniques like penile inversion, where they basically split and invert the skin of your penis. They take care of other parts of you. They form a clitoral head and hood from the different parts of the tip of your penis because that's where it's most sensitive. And that's one of the general techniques with that. We'll get into it a little bit later when we talk about puberty blockers. The issue with using that specific technique, because it issues with having enough length. You have to have a certain amount of length to be able to effectively have a deep enough vagina to be created using that method. So if you don't have enough length, that method's usually not recommended. There are other ways to do your gender reassignment surgery, but that one's usually falls down the list because you don't have enough skin and things to be able to move around to do that. And then so that's for natal males, for natal boys, and then for natal females or girls, a mastectomy, which is the removal of the breasts, or a phalloplasty, which is the creation of a neopenis or a penis from a few different ways. One method is using, they take a flap of skin off of your upper arm and they can use that in the creation of the new penis. There are methods with the transgender males to give a more functional penis because right now technology and development of methods for this specific procedure are farther behind than the other treatments for the other direction. This is mostly associated with the fact that, one, we've only really been able to do a lot of the specifics associated with, for example, the first penis transplant was within the last decade. I think it was within the last 5 years. You know, the first true successful penis transplant. Two, the techniques we've been using for the vaginoplasty, for creating the vagina for transgender women, those are techniques that have been kind of basically reused from women who have had uh, trauma to their vaginas from things like car accidents, industrial accidents, spousal abuse. You know, in certain areas, you know, you'll have based on religious traditions, you know, they can horribly scar up and cut up the vagina or the clitoris because of their religious beliefs. And this technique level was developed to help women address those deficits. That's why the ability for transgender male to female, they're able to have more functional and more realistic looking new parts is because of that. There are there are works on ways to help address the lack of skill and technique in what we have right now for transgender men. But again, it takes time, it takes research. It also takes people willing to try some of this stuff on too. Plus, you're also talking about the amount of people who are transgender men versus transgender women. At least the number of ones who were out is a lot different. The statistics bear more in favor for transgender women. So specifiers, uh, so like I said, the specifier of post-transition. So the rest of the DSM for each of the sections for whatever diagnosis you're looking at. There's several different sections. You have the diagnostic features section, which is this one. And what that does is if you go through and read all of this, right, is it explains more in detail the different things associated with each of the criterion listed above. So it'll go through and basically almost in order go through and explain the different criterion. So if I jump down here to, for example, this paragraph here. So gender dysphoria manifests itself differently in different age groups. Prepubertal natal girls with gender dysphoria may express the wish to be a boy, assert that they are a boy, or assert they will grow up to be a man. They prefer boys' clothing and hairstyles, are often perceived by strangers as boys, and may ask to be called by a boy's name. Usually they display intense negative reactions to parental attempts to have them wear dresses or other feminine attire. Some may refuse to attend school or social events where such clothes are required. These girls may demonstrate marked cross-gender identification in role-playing, dreams, and fantasies. Contact sports and rough and tumble play, traditional boyhood games, and boys as playmates are often preferred. They show little interest in stereotypically feminine toys, for example, dolls, or activities, example, feminine dress up or role play. Occasionally, they refuse to urinate in a sitting position. Some natal girls will express a desire to have a penis or claim to have a penis or that they will grow one when older. They may also state that they do not want to develop breasts or menstruate. So again, you'll see the alternative, the inverse with natal boys. Prepubertal natal boys will express the wish to be a girl or assert they are a girl and that they'll grow up to be a woman, that they have a preference for dressing in girls' or women's clothes, or may improvise clothing from available materials, like using towels, aprons, or scarves for long hair or skirts. These children may role-play female figures, example, playing mother, and are often intensely interested in female fantasy figures. Traditional feminine activities, stereotypical games, and pastimes, like I said before, playing house, drawing feminine pictures, watching television or videos of favorite female characters are most often preferred. Stereotypical female-type dolls, Barbies for example, are the often favored toy, and girls are the preferred playmates. They avoid rough and tumble play and competitive sports, and have little interest in stereotypically masculine toys like cars and trucks. Some may pretend not to have a penis and insist on sitting to urinate. More rarely, they may state that they find their penis or testes disgusting and that they wish them removed, or that they have or wish to have a vagina. In young adolescents with gender dysphoria, clinical features may resemble those of children or adults with the condition, depending on developmental level. As secondary sex characteristics of young adolescents are not fully developed, these individuals may not state dislike of them, but they are concerned about imminent physical changes. And that is one of the reasons you see a lot of desire and push in children and adolescents for puberty blockers, especially when we're at the ages where onset of puberty is about to happen or may have already started. And so I'm not going to go into the adult section because we're not here to talk about adults. Uh, like I said before, the prevalence for natal adult males is 0.005% to 0.014%, and for natal females, 0.002% to 0.003%. Again, I said the numbers are pretty far off. It's a lot different. You're talking at least a 3 times difference, if not more, in the number of, you know, natal males versus natal females who are experiencing gender dysphoria. One thing to remember as well is not everyone who is dysphoric will end up transitioning, and not everyone who transitions will transition with the intent to go the full way for surgery. So you won't always see someone who goes straight or all the way down the line to having, complete genital reassignment surgery. They may only do, for example, female to male, a mastectomy to help create a flatter chest appearance, along with testosterone for hormone replacement therapy, versus having a genital reassignment surgery, which with current technology, you're not getting the same level you would if it was the other way around. So, again, development, of course, can vary. Again, it depends on different things. Young children are less likely to have the signs and symptoms of their desire to be the opposite sex persist into adulthood. That is one thing that we'll see later. Is you'll see children, younger children, prepubertal children will have that, where they won't necessarily end up transitioning. It's like, if I remember from my research and my note typing, it was like 80 to 85% end up maintaining their natal gender. And so that's one of the reasons you see a lot of people push for, and you see with the passage of something like HB 1570, the desire to reduce the amount of people who are able to have access to those. But I'm also going to touch on it in a bit, some of the reasons why we have that. Now, remember, that was for children. Adolescents, it's a bit different. Adolescents, the shift kind of goes the other way. It's more than the majority, if I'm remembering correctly, will want to persist with their gender that they're wishing to now identify with versus their birth gender. So, again, one of the things too when we talk about this is, as I mentioned, there is a history of with people who have disorders of sex development, like ambiguous genitalia, like hermaphrodism, which was the word I couldn't remember earlier, uh, where they might have a penis, but it's small, and they also have a vaginal opening, but they don't have internal reproductive organs of a female. There used to be an issue where they would take boys and adjust and do surgery on the genitals to make them look like girls. And one of the issues you would have is you would have these boys being raised as girls and having nothing to want to do with it because they were forced into it in a way. And they're experiencing what is effectively dysphoria because they are not with their identified, their assigned gender. Because that's a case where it's not necessarily your birth gender, because your birth gender, while you may have sex hormones and sex chromosomes of male or female, because of your, say, ambiguous genitalia, you were assigned a gender of male or female by your parents, by a physician, by a surgeon. And now that assigned gender does not match how you feel on the inside, does not match your feelings, does not match the things you do, does not match how you behave, does not match how you act. So I believe, like I was saying, there's a lot of this diagnostic criteria stuff. It goes into the history, you know, how, for example, on this section specifically, how it develops for people without disorders of sex development, which you see here. And on the next page, we have gender dysphoria and how it develops for people with disorders of sex development. Another big section of the DSM is risk and prognostic factors. So, temperamental, environmental, what does it do for your temperament? How does environment play a role in all this? Genetic and physiological, which is right here. How does genetics and physiology play a role in this? There's also, you have to factor in culture related diagnostic issues. You may have heard in different discussions or political issues on this topic, for example, Native Americans having a third gender identity that's not male or female. So, is their culture have a role to play in their dysphoria? Um, is their culture for boys enforce a strongly masculine expectation regardless of what you end up being as a person? So, your normal level of society versus a 5 out of 10 average level of expected masculinity, they want you to be like 8 out of 10 masculine. You need to be masculine. There's no showing any weakness. There's no showing femininity. There's no being a sissy. You can't be a pussy. None of that. So, with that increased level of social and cultural expectation, you may experience some dysphoria, even if it's not enough to transition, because you don't necessarily identify with that. You're having, you may be a boy, but you're not necessarily to that level of masculinity. You don't have the same level of investment, right? In in it, and those kind of things, culturally related, can impact someone's dysphoria. You also have diagnostic markers, so things that will help with identification of it. You have functional consequences of gender dysphoria, and that's the real big one here. Is when you have something like this, it can impact, for example, peer relationships, because you're failing to develop same-sex relationships. So, if you're a boy who wants to be a girl and all you're doing is being friends with girls, you're not developing any male friends, and vice versa. You know, it can impact your daily activities. It can impact, the way you dress. It can impact how well you get along with your peers. For example, is if you feel more feminine and you were born a boy, you may wear stereotypically feminine clothing, and that can impact your social development. There are other things as well. I'll leave this up again on the screen for a few minutes while we talk through some of it. So this section here, this is the differential diagnosis. So channel Dr. House for a minute if you've ever watched the show. So what this means is, what other things could the symptoms being displayed be? So if I have someone come in front of me and sit with a level of symptoms, is it possible that it's gender dysphoria? Or is it possible it's one of these other things? It's a good question, right? So how do you determine that? Well, that's kind of what this is. So what the differential diagnosis does is it gives you different conditions that the symptoms you're seeing could be, and what likely points it towards that or not. So, for example, transvestic disorder down here, right? So, transvestic disorder occurs in heterosexual or bisexual adolescent and adult males, rarely in females, who cross-dressing generates sexual excitement and causes distress and or impairment without drawing their primary gender into question. So that's the key part. Is they're engaging in this behavior, but it's not calling their primary gender into question, right? They're engaging in it, they're doing it. You as a parent may not like it, but it has nothing to do with who they identify with. It's more of a sexual gratification. It's not necessarily associated with their identity. Again, body dysmorphic disorder, another differential to consider down here. So sometimes you'll see this used in reference to people who are transgender or who are experiencing gender dysphoria. In and of itself is not an appropriate diagnosis for a person being transgender. It does get used inappropriately. So the differential for this, an individual with body dysmorphic disorder focuses on the alteration or removal of specific body parts because it's perceived to be abnormally formed, and not because it represents a repudiated assigned gender. So that is the part that is the critical key right here. Not because of being a body part that isn't associated with a gender. Their focus is solely on removing what they feel is a disformed or disfigured or abnormal body part. It has nothing to do with the gender identity itself. The gender dysphoria itself, the distress of being in that identity, being forced into an identity and gender you're not. When you put the two together, you have, yes, you want to remove the part or you want to add the part if you're wanting to get full surgery. But in general, just wanting the parts to go away, if you're transgender, if you're wanting your identity, doesn't mean you have body dysmorphic disorder. If you just want the parts to go away, has nothing to do with your identity. That's where body dysmorphic disorder, you would definitely factor into your differential. You also have to talk about in the topic of di- diagnosis for gender dysphoria, schizophrenia, or another psychotic disorder. Are we talking about a delusion? Are we talking about a situation where they're not necessarily all there right now? That happens. There can be other things too where, again, down here, so other clinical presentations, is it something else that's going on that, is happening? So what can we do to help address that? Comorbidity. So comorbidity being different things that can present with the disorder. So since we're talking about gender dysphoria, what are the different things that can, present with gender dysphoria? So different things include, uh, you know, depression, anxiety, sometimes behavioral problems in older children. Um, Depending on if it's a Western culture or not, there's other factors that can go into it. Autism spectrum disorder does have a comorbidity with gender dysphoria in some cases. There is some there's statistically significant research showing a link between autism and gender dysphoria in some cases. Doesn't mean if you have one, you have the other. So, but it is an interesting observation nonetheless that I myself wish I had more time to dig into. So another couple things you'll see here, and I left on this page on purpose, is and you see this with pretty much a lot of things in the DSM, is other specified. God damn it, give me a second. So you have other specified gender dysphoria and unspecified gender dysphoria. So what that means is for other specified is the symptoms are presenting, but they don't meet the full criteria for a diagnosis of gender dysphoria, but the diagnosis might be helpful. For example, brief gender dysphoria right here. There might be a situation where that is a useful diagnosis. Or you may have some symptoms again, but not enough. And diagnosing it or keeping it recorded in the medical record can be helpful not only to yourself, but to future clinicians, future people who might get involved. So if a future doctor comes in or someone tries to go and get surgery, does this help them or does this hurt them? Does it point to something else? Is it keeping, because the goal that we'll talk about with the standards of care, especially with adolescents and children, is there's a few different types of transitional medical care. And if you go back to a core medical tenet of do no harm for doctors, is doing harm through any of those interventions an okay thing? Are they able to truly make that decision? And we'll get into it. And also for other specified, if they are showing the symptoms, but it's been less than 6 months. That's also the factor in as well. And then you also have for unspecified, you have symptoms which are characteristic and are causing distress, but again, don't meet the full criteria. It's used in situations where the clinician chooses not to specify the reason the criteria are not met, and includes presentations which there's insufficient information to make a more specific diagnosis. So you may be showing signs and symptoms of it, but I'm not yet ready to fully assign you a diagnosis of gender dysphoria. there may be other things that I need to make sure get addressed first that are very important to take care of before we cross that barrier, before we start, letting the clock tick away. So, next section, real quick, I'm going to check and see if anyone's commented. I know I haven't been paying attention to the chat. So, I don't think I see any new comments at this point. So, the next part, we're moving on to the standards of care, which are on version 7. These are established by the World Professional Association for Transgender Health, also known as WPATH. So briefly, I'm going to talk about the standards of care. I'm going to talk about WPATH itself. So WPATH was originally formed in 1979 as the 𝐓𝐢𝐩𝐬𝐵 International Gender Dysphoria Association, or also known by the acronym of HB1570, which I'm not even going to begin to try and put words or pronounce it into some sort of form, because why not? So, like I said, the first version of the standards of care is version 7, the current version, I mean. The first version was in 1979 when the 𝐓𝐢𝐩𝐬𝐵 International Gender Dysphoria Association was formed. Since then, we've had 6 revisions. We're on currently number 7. There were revisions released in 1980, 81, 1990, 98, 2001. Version 7 was released in 2011. The WPATH has been working on version 8 since 2019. I've seen some different information associated with the establishment of the standards of care for version 8. They're doing all the working groups and the different people that need to be involved, so that way the right amount of research, the right amount of information is presented. Another factor to think about too is in 2017, the Endocrine Society, so endocrinologists, which are people who deal with hormones, right? They're the people who normally will prescribe hormones for you if you're transgender. They're the persons who measure to make sure your hormone levels are good, make sure that you're not having any issues or anomalies associated with your transition. Because there are some health risks that can come with hormones, that can come with puberty blockers, that can come with like androgen blockers. So how do you deal with that? In 2017, the Endocrine Society released their version 2 of guidelines on transgender patients and the treatment of them, which I had the pleasure of researching and looking up recently. That guide itself is 37 pages. The section I cut out for this topic on just the standards of care from WPATH on adolescents is long enough. So I'll probably do a future video or stream on that. Now, there is some controversy over the standards of care in general. Some of those were addressed with the recent versions. There still exist. There was an issue with the standards of care setting a minimum time requirement for counseling. You had to be in counseling for so long before you could get prescribed hormones for adults, for example, before you could get prescribed hormones or before you could do certain things. There was also the issue that with the controversy from certain people and certain groups of the having to pathologize it, calling it, a disorder of development or disorder of sex, which they did change the wording. They have become a bit more culturally competent on the topic. But, just like anything, and I'll be the first person to tell you, don't necessarily take everything you hear with a grain of salt. Feel free to do your own research, dig into this shit. This is a very complex topic. Even in grad school, I did a whole long ass paper thing on this topic, on the origination and history of trans people, transgender, what it means, the first successful transgender surgery, how we got to where we are today, where are we potentially going in the future. It was a lot, and I barely scratched the surface And this was also in not undergrad, grad school. So make sure you're not just hearing one side of it. Yes, you may run across some information that makes you uncomfortable, and this isn't just in one direction. You may not like the fact that this is a thing and that people are actually trans and that there are cases where prescription of puberty blockers and prescription of cross-sex hormones for people who meet the right criteria is appropriate because of their significance of their dysphoria, because of the issues they're having. Some people, I've had many debates over this with personally in my personal life on whether or not trans people are just gay or lesbian or something else. That does happen. That doesn't mean it's always the case. Again, you'll see it with younger people. They're experimenting with their gender identity doesn't necessarily mean they're trans, but it's helping maybe them come into their gender or sexual identity. So their exploration with some of the gender identity stuff helps them realize their sexuality, but they all end up being trans as a result. So this is the, like I said, this is the standards of care. This is uh, the cover of the book. Like I said, it's 100 and some pages at this point for the 7th version. So, like I said, this is one of those sections where there's a big white section up here because I removed material that wasn't important. So, section 6 of the standards of care specifically talks about the assessment and treatment of children and adolescents with gender dysphoria. So, this is a very, like I said, controversial and complex topic. So, the purpose of the WPATH standards are to provide a starting place for providers to work from. You'll see in the wording, if you read it yourself or if you read it as we go through, some of it will say that, these are somewhat guidelines and they can be flexed a bit. Should you flex them? In certain cases, there's arguments to be made both ways. But in a general sense, this is the place we should start from. This is where we should really take into consideration because you're talking about minors, you're talking about children and adolescents, and those are issues whenever it comes to how do I deal with these? How do I make sure I'm making the right decision here as a professional? If I'm working with a person who's 12, 13 years old and they're transgender, and their eventual goal would be to get on puberty blockers so that they can, at some point in the future, decide to get on hormones, I'm going to come back to this because this is the place to start from. Because at the end of the day, I need to make sure I'm putting in the best care for them. Have there been providers out there that aren't looking out for their clients, aren't looking out for their patients, are using, you know, a political message maybe to help further a means to an end? I mean, that happens with a lot of things. I've seen examples in this situation, in this environment, in this community where that's happened, where people are either A, forced to not be okay with being trans, or B, they're forced into being trans, even though they don't want to be or they're not, because maybe their parents are very supportive of the community. Again, this is the rare minority, but my point is it does happen. I've been involved in different support groups and communities where just addressing the topic, I've been called transphobic. I've been called homophobic. I've been called misogynist. I've been called some other things too. But I'm also a provider who specifically chooses to work with this population who does provide gender affirming care. It's my God. It's my job. That's considered the gold standard right now. So, like I said, these standards are meant to help, give you a place to start from. We're also going to address HB 1570 after this, which is the Arkansas SAFE law that was just passed, or SAFE Act. There's also other bills in the country that are making their way through state legislatures with a similar message and intent. South Dakota is one of them. So keep an eye out for different bills like this. I'm sure they're going to come up, and I'm sure there are going to be lawsuits about them. If you're interested more in the law side of things, check out 𝗓𝐬𝐻𝐬𝗏. I'm sure he will do streams on that, and I wouldn't be surprised if, you know, I pop in for a discussion on that as well. So when we talk about gender dysphoria, like I mentioned earlier, it doesn't always transfer to adulthood, which is why we have to manage interventions properly, because it's critical to prevent harm when we treat gender dysphoria in adolescents and children. Again, it's more common for adolescents to continue forward with transition, but at the writing of the Standards of Care in 2011, there is no formal research and studies on that. We do have research showing children don't inevitably continue to transition into adulthood, nor does their dysphoria continue into adulthood. So, again, this is mainly prepubertal children who had persistence into adulthood, which I believe the number is right here of 6 to 23% of children had their dysphoria persist into adulthood from a sample group of, I think it was 70 something or 80 something. Let's see here. They were more likely to identify as gay in adulthood, but again, one thing to consider is some of these studies were late 80s, early 90s, early 2000s. The level of acceptance for not only the LGBT community, but transgender people themselves has changed in the last couple decades. Within the last decade, we've legalized gay marriage. It is socially more acceptable. So just because someone goes from childhood to adulthood, ends up not being dysphoric, now that same child may experience it differently. It's really hard to say. Plus, it's also really hard to do research with children. Anyone 12 and under trying to do clinical research on, getting the approval for that is difficult as shit. So that's why you see normally a lack of research with things associated with medicine in children, because it's hard to get approval from the boards at universities on whether or not it's safe to do those things. Uh, I've looked into doing different types of research, and I've seen the struggle you can have with just getting approval for simple things. Uh, Again, as I mentioned earlier, there is a significant difference in the ratio of boys to girls, talking about natal gender who are experiencing gender dysphoria. And normally with kids, boys, so under 12, boys 6 to 1 or 3 to 1 in that range. Boys to girls have gender dysphoria. The gap closes as we get into adolescence and into puberty. So moving on, it's common for children, and not only children but adults as well, to have coexisting disorders such as anxiety and depression. Because if we remember the definition in the focus on what dysphoria is, because you can have dysphoria and it's not about gender. So it's being uncomfortable, it's being, there's issues associated with that. And so if you're uncomfortable with your gender, if you're uncomfortable with who you are as an identity, yeah, you'll probably have a comorbid disorder such as depression. You'll be depressed because you feel like you can never, fully be who you really are. You're stuck in a body, you're stuck in a place, you're stuck identifying as something you can't be. You have anxiety with social situations because, if you're, say, at home or in your private life, letting your identified gender be more prominent, but in public, not so much. What happens if you slip up? What happens if you use, your female name instead of your male name in public? Or if you trust certain people and they slip up and call you by, say, your female name versus your male name. So there can be anxiety about social situations, about people, addressing you by the incorrect pronouns. Uh, there is, I will be forward. I do have a mild personal issue with the over persistence of forcing of pronoun usage. One thing I teach all my clients is you are in control of you and your emotions. You do not get the ability to dictate someone else's behavior. You may ask, you may request, but you cannot dictate at the end of the day someone else's behavior. I'm sorry. Does it suck? Yes. Do I wish it was different? Probably not, because I don't want to force anyone to do anything. So if someone's dealing with significant anxiety and depression because of their identity, not just children and adolescents, the fact that they're being misidentified with their pronouns can be triggering for them. It can cause anxiety, it can cause depression, it can cause them to feel shitty about themselves. Now, does that mean pronouns should be weaponized? Probably not. Should you be forced to use them? I personally disagree with that. Should you, as a general rule, try to do your best to respect it? I would say if you can. Again, it's up to you at the end of the day, but if you're comfortable with it, if you're okay with doing that, go for it. If not, again, that's your call. I don't care. The only reason I wouldn't do it would be very rare, but it would be on a personal scale only and only in certain situations. Would never do that in a professional role. Uh, so, like I said, there are comorbidities with gender dysphoria. It can disappear before puberty, as far as the dysphoria, or if it does persist into puberty, it may have a stronger likelihood of persisting. Uh, One issue you will see, and it has been one of the driving issues between this debate on the ability for kids to have access to this, to medical transition, is because of the level of depression and anxiety and other things they may be feeling associated with their gender. They want nothing more than to make it go away. And the only thing they may see is, I know I can take hormones. I know I can get surgery and it will make things better. That's not always the damn case. This is where one of my personal issues comes up on the fact that we're pushing this as a solution, that this will make everything go away, make everything better. As a provider, when I talk to people who are transgender, I always make sure to let them know and discuss the possibility of, you may go through all of this stuff. You may have surgery. You may be on hormone. You will now be on hormones the rest of your life. What happens if you don't get that feeling of relief you're looking for? What happens if it doesn't really make things better? Can you be okay with that? Because that's a realistic possibility. There is no magic button to make shit go away. One issue you'll also find with this, and a lot of the miscommunication I feel with children and adolescents, is they don't understand the difference between being a biological woman versus a trans woman, or a biological male versus a trans male. Because, yes, you do identify with being a female, but current technology does not allow you to be effectively a full biological female. You have to be okay with being a transgender female and what that means. You know, not being able to have kids on your own, not having a menstrual cycle, having to deal with other things biological females may not. Same thing with biological men versus transgender men. Current surgeries, you're not getting a penis that will become fully erect on its own. You may not have a penis with significant length enough for penetration. It's more a cosmetic feature. Are you going to be okay with that for the rest of your life? You're going to be okay with being on hormones? You know, I make sure to prepare the people I talk to in this topic about that. I feel it's only fair to them. Now, I will support them, but it is a disservice to them if I don't make the information available and discuss the possibility. Because that is one of the things you have seen with people who do regret and do revert back to their birth gender, who will untransition, detransition. They thought that it was a cure all. They thought that they were going to be a woman or they thought they were going to be a man. And guess what? They weren't able to reach what in their mind they thought they were going to be. So that's something that's very important to factor into this. Often kids will push for hormones, puberty blockers, surgery. They want it now, they want it now, they want it now. Sometimes they'll go out on a limb and do things like getting access to hormones online because it's not that hard to find an online pharmacy to send you estrogen or to send you testosterone. I can do it in about 5 minutes if I want to. So, to a certain extent, yes, you can limit their access to things like medication inside of the current medical system. But this is where the therapeutic side is so important in addressing some of these underlying issues is the dangers of doing it on your own, the dangers of not having medication management, the dangers of not having your blood and hormone levels checked all the time, the potential for shit like a clot that could throw and then you end up stroking out, brain damage because we took medications from an unknown online pharmacy. That may be perfectly legit, but the issue was not so much bad medication, it was bad management of the medication. They weren't getting the effects they wanted as quickly. They upped their dosage. They should have been on a lower dosage because of other health issues. So these are all the things to factor in. So a lot of issues that you come into this as well is parents' comfort and discomfort with their kid being trans. You know, parents don't always like the fact that their kids are trans. Some parents don't believe it's a thing. Some kids have an issue and some kids don't get the treatment they need because medical care is just as important as psychological care in this case. So, if we move forward, when we talk about treatment for adolescents specifically, because those are the ones you're more likely to see with puberty blockers and older adolescents' hormones. So I'll probably just refer to adolescents moving forward, but kids and adolescents who are referred to clinics like these normally will need to be in Tanner stage 2 to 4, which will show up in the next slide, which I'll go over real quick, to be able to getting access to puberty suppressants, getting access to be able to do that, because that's an important part of the piece. And that's how you know you've begun the process of puberty because you have a change in your Tanner stage. Because Tanner stage 1 is normally associated with pre-puberty. So one also issue you run across is clinicians thinking of dysphoria being a delusion. Like I mentioned earlier, delusions are different than dysphoria. It's very unlikely someone with gender dysphoria is also comorbidly or concurrently suffering from a psychotic disorder or from a delusional disorder. Yes, it can happen, but the odds are very low. So misdiagnosis is also an issue as well. It's not uncommon still to run across older providers who still use the DSM-4TR instead of DSM-5. And so the diagnostic criteria are a bit different, and in some cases a lot different in diagnostics for things. So they may be diagnosing something inappropriately because they're using an old standard, or they're not taking into consideration culturally competent factors in diagnostics. Um, like I mentioned before, anxiety and depression, oppositional defiance, behavioral things, those will all have a higher prevalence and more likely to be comorbid with someone who's experiencing dysphoria as an adolescent. You're dealing with all the stress that comes with not being comfortable in your body, along with all the stresses of being a preteen and a teenager. So, and like I said earlier, there's also a link with a higher prevalence of autism spectrum with patients who have gender dysphoria. Now, this part is more specifically about providers like myself. The competency of mental health professionals when working with children and adolescents with gender dysphoria. So, at a minimum, these are the following recommendations: meet the competency requirements for mental health professionals working with adults, is outlined in Section 7, which I don't remember if I included in this. I can pull it up briefly to go over it outside of the current slides. They are also trained in childhood and adolescent developmental psychopathology, the way kids develop as they go from different stages, the cognitive changes, the body changes, the social changes they go through, all matter in the diagnosis. You have to also be competent in diagnosing and treating ordinary problems of children and adolescents. If I am only a provider for adults, and now I'm just going to suddenly start prescribing gender dysphoria in children, and only children, but I am not competent in diagnosing stuff like ADHD, oppositional defiance, conduct disorder, other things, right? If I am not able to differentiate, is this depression in a child? Is it an adjustment disorder? Those are all factors that play a part in the overall diagnosis. Because there is a lot of comorbidities, but there's also cases where, like I said, your differential diagnosis of how do I separate these issues out. Also, diagnostics are difficult in general. Like I said, some providers aren't culturally competent. Some providers aren't necessarily skilled in working with the LGBT population. So that's also another factor. Now, the roles of mental health professionals working with children and adolescents. So this is very specific, not just in general. We're talking about being able to directly assess gender dysphoria in children and adolescents. See the guidelines below, which we're going over. Provide family counseling and supportive psychotherapy to assist children and adolescents with exploring their gender identity, alleviating distress related to their gender dysphoria, and ameliorating any other psychosocial difficulties. Assess and treat any coexisting mental health concerns of children or adolescents, or refer to another mental health professional for treatment. Such concerns should be addressed as part of the overall treatment plan. We cannot just treat one of the pieces of the puzzle. We can't just treat the dysphoria and hope the depression goes away. You also have to treat the depression if it's present. You have to treat the anxiety if it's present. You can't just try and do one piece. You have to work with all the other things. And yes, is it complicated to do multiple things like that on a child in treatment, especially for mental health? Definitely. But you can't just pick and choose. Also, referring adolescents for additional physical interventions, such as puberty suppressing hormones, to alleviate gender dysphoria. This includes documentation of the assessment of the dysphoria and mental health of the adolescent, their eligibility for physical interventions, which are also outlined below, and the mental health provider's relevant expertise and any other information pertinent to the use, health, and referral for specific treatments. One thing you'll often hear in regards to transitioning and either starting hormones or puberty blockers, not just in adults, but in children as well, is the letter. To be eligible to get hormones or puberty blockers, you need at least one letter from a provider like myself or another therapist saying that you meet the eligible criteria and that they are referring you for that type of treatment. Surgery for anything other than a mastectomy requires two different providers providing you letters, which we'll touch on later. Also important in treating this is educating and advocating on behalf of the dysphoric children, adolescents, and their families, not only in their community, such as daycares, schools, and other stuff. It's also important to conform, that children who don't conform to socially prescribed gender norms, recognizing that they're more likely to deal with harassment in schools. They're more likely to deal with social exclusion that other people may not. So keeping people in their environment, such as schools, such as daycare, such as after school care, up to date on, hey, this is a thing one of your children in class or one of your children that you oversee may deal with. How do we prevent them from dealing with the risks for social isolation, for depression, or anything else that could come along with it? Also, providing children, youth, and their families information and referral for peer support, such as support groups for parents of gender nonconforming and transgender children. This is more adult related, but one issue you see with adults is for adults who are, say, married and one of the people in the relationship transitions, is you have spouses who do not get the support they need. In many cases, they feel like they're losing their partner. A lot of times, those relationships don't always end up staying together. Sometimes they're able to adjust to their partner's new gender. But one of the issues that often gets misidentified and overlooked is you are effectively losing someone. It is basically the death of someone. John is dying and Jane is becoming born. They are now Jane. They are a new person, right? John is no longer really here. They're a different person now. In that it's not the person you may have married, it's not the person you may have originally fell in love with. You are losing them to some extent. And that is a difficult thing where spouses get sometimes left behind and there's not enough support groups out there for people in those situations. Just like this, we're in a situation right now, well, we do have the benefit of this being a more open topic in general. Parents are still struggling with being able to adjust, getting the support they need to understand the different pieces of the puzzle. There's only so much you can do a week for therapy. Sometimes you can only afford an hour a week. Usually that hour a week in this case would be dealing with the child or dealing with the child in the family perspective. The parents may need their own counseling with a provider who's an expert in this to help deal with the, child's gender, the child's identity, and if, for example, say my office doesn't have the ability to do it, it's important to refer out, but not only the children, but their families to other agencies, not just for psychological services, but for endocrinology. You may not have a doctor's office and a mental health office that are working as a unit to do both of these. It's not like an overarching organization. A lot of the times it's someone goes to therapy and they get referred to an endocrinologist for this. So sometimes the endocrinologists aren't always up to date on dealing with this as well. So helping the doctors understand the care, giving them something like they may not be familiar with the endocrine society's standards of care. There are guidelines for treatment with endocrinology. So helping the providers, in my role, it would be important to help support all sides of the puzzle, all people at the table, not just necessarily my client directly. The people I'm working with are just as important. My professional allegiances and alliances with other people in the community. I benefit and my client benefits from helping them. because you're still talking about a very critical decision to make for a child or adolescent when it comes to these physical interventions, which we're about to get in touch with and we're about to talk more about. So we'll kind of move on to that, right? So there are several pieces to this. You have to do the psychological assessment of the child. You know, you need to be able to be like I mentioned before, affirming care. You have to recognize the concerns of the child and their families. Again, recognize that not everyone's always on board, not accepting. But we need to bring this stuff up out of the shadows and into the light so we can discuss it and actually start working on it. We do these assessments not only on the disorder, but on social relationships, on their functioning in school, on their developmental level. These are all helpful in determining the right type of intervention or interventions the person will need, the child or adolescent's going to need, right? Some things are more helpful than others. Some things may be harmful in certain extents, right? Not just medication wise, but therapy wise. Some types of treatment they may not be ready for because they're more difficult. They're not comfortable enough yet to do something like that. You know, if you're not ready yet to go and present socially, I can't force you to go present socially full time. Just like I can't, if you're afraid of spiders, I wouldn't expect you to be able to hold a tarantula today. You have to do it slowly, you have to do it right. So, again, as I mentioned earlier, and you'll see in number 3 of the assessments part here, informing the child and their parents the limitations and the possibilities about treatment. This is required for not only informed consent, but I believe, in my personal opinion and professional opinion, it is in the best interest of the client because the way they respond to that will be helpful in your diagnosis. For me, for example, right? If I tell them, well, yes, you can transition, but you also have to recognize that you're not going to be a true biological woman or a true biological man. So, how do they deal with that? Does it cause them a lot of distress? How do you address that? There's a lot of pieces to this puzzle. It is not easy. You know, talking about psychological and social interventions for children and adolescents. So these are the things that aren't medications. They aren't puberty blockers. They aren't surgeries. You're talking about acceptance, not only of self, but from family, from siblings, you know, getting peers and mentors of them in the community to support the child's identity, to help them work through their dysphoria. You know, the goal of psychotherapy is to focus on reducing the distress related to their dysphoria and helping address other issues like depression. If their goal is sex reassignment, the goal is to focus on supporting them before, during, and after reassignment. Evaluating the different psychotherapeutic approaches haven't necessarily been published, but several counseling methods are out there in working with gender dysphoria with transgender clients. Where treatment is aimed at helping the person's identity become more congruent with their with the sex they wish to identify with. It's you have this issue with their identified gender and their physical gender or their physical sex. There used to be, and this is what this is talking about right here in this pink section. This is specifically referring to kind of treatments like conversion therapy, right? Conversion therapy for homosexuality. We'll make you straight. We will pence the electric fence, shock your ass to straight and heterosexuality again. The same thing for this. It is unethical as a provider to tell my client, oh, these feelings you have, you know, we'll make you be okay with the fact that you're a girl or a boy. That's unethical. There's a lot of reasons why, and that might be its own separate set of discussions. But, there are a lot of things to deal with and manage here, like managing anxiety about the outcomes. You know, how does the child develop their sexual identity as they go through this? You know, not imposing a binary view of gender as a professional, giving the ability for the child to explore their expression of their gender, addressing hormonal and surgical interventions that are appropriate for the specific client. One client may be perfectly appropriate for full transition, and another is absolutely not appropriate for transition as an adolescent, and maybe ever, because of what their situation is. You can't apply a broad rule to everyone. This is a situation that requires finessing. These are difficult decisions. You need to be able to express your identity as the person dealing with it. You know, for that social part, supporting a child who's undergoing their social transition partly. You'll start, you know, with social transition. It's not like I'm going from, okay, I'm Jack today and I'm Jill tomorrow. You may start with presenting feminine, for example, just on the weekends or on vacation or in the comfort of people you are okay with because they're there to be supportive. And as you become more comfortable in your own identity, then maybe going out in public on the weekends, then maybe going to a summer camp, maybe not with people you're familiar with. That way it doesn't come back to you at school if it doesn't go well. And then if you're comfortable, when you're ready, you can transition socially enough to be fully socially transitioned to be able to go to school. You know, dealing with the stress that comes up along that process. You know, when we talk about therapy, it's important to help maintain a strong level of trust and a strong therapeutic relationship with the client and the family because you're going to have so many things that come up along the way. You need to be able to ensure that the decisions on the treatment are thoughtfully and reconsidered pretty often. It's not something you make a decision once and we say, okay, we're doing this, and we never look back at it again. We reassess as we go through. We reassess and say, okay, this is what's going on. This is what's happening. And so maybe this is dictating a change of what we need. So, real quick, before I move on to the next slide, I'm going to address a topic or a comment that was mentioned in the chat. And so, someone had mentioned in chat, if we had lived in a sane and decent world, any parent who let their kid mutilate themselves would be thrown in prison for life. Disgusting, right? I haven't yet got to the point where we talk about physical interventions and the limits that come with it, right? So when we talk about the limits for physical interventions, no 6, 7, 8, 9, 10, 11-year-old is getting a physical intervention. No 12-year-old is getting a physical intervention, most likely. The goal is normally to aim for like 12 and up for physical interventions. If you do them. To me, what's more disgusting is a parent who knowingly lets their child suffer with a psychological condition that, untreated, causes them to hurt themselves or kill themselves. Because while as uncomfortable and distressing as it can be to deal with a child who is trans, it is even more fucking worse and more horrible as a parent to lose a child. You hear the statistics, even though they are misquoted and misrepresented about trans suicide. It is high. It's also high in children. Suicide in general is high in children. Add this on, and then makes them even more risky for suicide. These decisions should not and are normally not taken lightly. These are not decisions that get made without constant reassessment, constant inclusion of the family. A kid by themselves can't just make the decision to transition medically outside of the age of medical consent, which in the United States usually varies from 14 to 18, state by state. So that's the age where you can medically consent to treatment. You don't necessarily need your parents' consent to treatment in some cases. It's also very dependent. Some people, yeah, their states allow some of it, some don't, right? But you're not getting hormones at 12 without your parents' consent. Without not only your parents' consent, your own consent, if you truly understand what that means, your therapist's consent, and your endocrinologist's consent, because they all are involved in this process. No child is having genital reassignment surgery. It's unlikely a child will be able to have genital reassignment surgery. A lot of providers would probably not do that anyway, because the risk for things to go bad is there. So we deal with that by doing it in another way. That's why puberty blockers are considered a form of treatment, because we can suppress puberty, allow them to mature a bit, socially, cognitively, and make that determination for themselves as they become more understanding of their gender identity versus jumping on the decision and then having regrets, right? So, real quickly, wanted to address that before I forgot. So, like I said, our goal is to help and reassess ongoing if we're doing the right treatment. It's no different than I do in my therapy practice. Each week, I'm following up with my clients. How are we doing? Are these things helping? Is there something we can do differently? Is there something we can do better? Are we meeting the goals that you set forth in therapy? Are we meeting the goals that you're setting out to reach in general? So, social transition in early childhood. This is, associated with, like I said, social transition. So, presenting as your identified gender. Um, this is controversial for younger kids. So, under 12, again, the issue with maybe preventing some of this or preventing at least some of the experimentation and coming into the person's gender expression is allowing a certain amount of social transition in early childhood helps with future clinical determinations. You can help make determinations regarding whether or not, this is going to persist into adulthood, whether or not when they reach a certain age, if they will be ready for puberty suppressors, puberty blockers. Parents, in general, from the standards of care, should help support a role change and expression of their gender, if as much as they can to extents. Again, keeping your therapist involved in the process. Not allowing the child to make the role transition. The parents may need counseling to help meet the child's needs, to help them become more sensitive and more understanding, and help provide more nurturing ways to address the issues. That way, you have a safe environment to explore your gender, your identity, your expression, sometimes even your sexuality. Obviously, not necessarily gender identity related, gender dysphoria related. For kids who are, for example, gay, who are exploring their homosexuality, exploring their bisexuality or other sexuality. If they don't feel supported, if they don't have a safe environment to discuss their issues, if they don't feel like they can talk about it at home, if they don't know it's okay to do certain things or not, it's not uncommon to see adolescents, 13, 14, 15, 16 year olds, jump onto stuff like Grinder or onto the lesbian equivalents to try and find social and sexual needs they can't get because they don't have that environment. They don't have a way to deal with it. You know, they're wanting to explore, but they can't. This is doing this by allowing your kid at home to, explore their expression, explore their identity. It gives them the ability to work it out. If they fuck up, if they trip along the way, you're there to help catch them as they fall. If they're doing it behind you, doing it outside the home, doing it without your understanding or your knowledge, or if they're doing it even though you don't want them to, they're doing it behind your back or they're doing it in a way you just don't recognize. You tell them no, they can't do that. I guarantee you they're keeping uh, something of their identified gender, either clothes or something, that they can use as an outlet for them. They're keeping it hidden under their bed or in their closet or in their dresser or behind a hole in the wall. For boys, they're keeping, female clothes to be able to dress up in, to help out, have them an outlet, to help them understand their identity by not supporting in some way. You don't have to be out the gate, go, oh my God, I completely, want you to do this and you're going to transition and have hormones. That's not the goal. The goal is to be there in a supportive manner. That's it. Just help them, support them. And if you don't know the answer, utilize the resources in your community and in your family in some cases. If you've got a therapist for your child, utilize the therapist. Come to the therapist and say, I don't fucking know what I'm doing. I don't understand how to deal with this. I grew up a certain way. I don't understand how this works at all. Great. We'll bring you into the fold. We'll help you understand a bit more. My goal isn't to, indoctrinate you. My goal is to provide you information. At the end of the day, what I want from people who leave my office is to feel like they got something out of it. If the client's a child of a parent or a family, I want the client, that child, to be able to feel like they're getting a benefit from it. And I want the parents to see that their kid is growing from it and getting better from it. So if the child comes into my office and they have dysphoria of their gender and some social experimentation helps alleviate that, and then a year later they go, I don't really think I'm trans. I just think, I was just kind of exploring myself a bit. Okay, cool. They're no longer feeling dysphoric. They're no longer feeling depressed and suicidal, maybe. Or their expression and ability to experiment with their identity helps them go, okay, I realize this is a big deal for me. I need to move further with this. This is a big part of me and I'm not able to deal with it right. So, next, we're moving into the physical interventions for adolescents. So, this is that key thing I was telling you about. There are three main types of interventions, right? Oh, let me go back. So, there are three types of interventions, right? You have fully reversible interventions, you have partially reversible interventions, and you have irreversible interventions. Our goal is to not get to, our goal isn't to jump down to this stage. We don't want that. That's not good. That's not good, right? We want to move in a step-by-step process in between these things, right? We want to make that shift because if we're up here, if we're on this, right? If we're on fully reversible, we can do something. And then if we do decide to flip the switch and go back to our birth gender, there's no permanent damage. It can be fully reversed. But if we come down, and we start doing this too soon, there are some things that you can't undo. You can't undo some changes of hormones after so long. There are some things that you can undo, others you can't. You have to factor that in. And then when you come down to here, if you have surgery, you can't undo that. Yeah, you can detransition from, say you go from male to female and then you want to come back to male. You are not getting the same level of function from a penis. If you get a penis back in it all, if they can even do it, if they have the uh, access to the parts of your body to be able to create a new penis, you are not getting the same type of penis. It is an irreversible intervention. You have to realize this is it. That's why you have to get surgical procedures as a person who's trans. The bare minimum, and we'll get more into this for irreversible things like surgery, you're living a full year as the gender you wish to be, fully out, fully living it. You were out as a woman, you were out as a man, and you were in it. You jumped in the deep end, and you're living that for a year. And at the end of the year, during the year, you're being assessed as to whether or not you're getting the pieces of the puzzle finished. You're completing the things you need to do. You're feeling more comfortable with yourself and with, the fact that I am actually a woman or I am actually a man, and I'm happy that I'm moving along this process. Or no, I am not. I am not trans. I am not a boy or I'm not a girl. I am wanting to go back. That's why you have to have a year of experience in that new gender. That's actually a controversial issue. There are people and there are pushes to change the standards of care from that requirement of not only 1 year, but not having to have two different providers sign off on it. Personally and professionally disagree with it. So, kind of jumping back, there are, in this fully reversible section here, that normally means, you know, puberty blockers, stuff like that, anti-androgenins, such as spironolactone, because I always pronounce that wrong. It decreases the effect of androgenins, so more masculizing hormones. You can take that without it causing permanent damage. Of course, like any medication, there's some side effects, potential medical risks. You can take medications like you can take oral contraceptives in a way to suppress menses. Once we get down to the partially reversible stuff, you're talking about hormone therapy. You know, again, like I was mentioning, some of the hormone therapy may need reconstructive surgery to reverse it. You know, you might have to, you know, for example, if you're a woman who's transitioning to a man and you take testosterone for a period of time, your voice is deepened. You are not undoing that. The only way you can undo that is with a lot of vocal training, and that's practice. And you're not guaranteed to get the same level of feminine voice you had. So, and if I haven't already apologized for it, I'm sorry for all the highlights. There's a bunch of different things I was trying to point out along the way, and some things that were more important than others for myself to kind of reference. So I kind of left it up. So if it looks like a child drew on this, I apologize. So, like I said, for fully reversible interventions, so that first stage of physical interventions, it is recommended that you be at least 10 or stage 2. You can be as young as 9. Again, that depends on your level of physical development, your level of pubertal development, right? So this is the Tanner stages I was mentioning. So for girls, Tanner stage 1 is here. You haven't hit puberty yet. You have no breasts. You have no breast buds. You have no pubic hair. You have no development of your, uh, vaginal area. It's not filling out like it does as you move into adulthood. And you haven't hit menses yet. You haven't started having a period yet, right? Menarche hasn't happened. Tanner stage 2. That's that key one I was mentioning, right? So at least standard stage 2. So for females who want to transition to male, you start having breast buds. You have that kind of wispy initial level of pubic hair, right? You need these as a bare minimum because that's, like I said, an indication you are moving into puberty. So that's how you know, okay, maybe we do need puberty blockers. So because you're hitting this, that's how you say, okay, we are hitting puberty. We want to pause the effects of puberty so we can give ourselves the opportunity to try and mitigate the effects of that. Just like with the effects you have with this says more pubic hair down here, but it's also referring to some of the other physical changes that happen. You want to pause those if you aren't sure yet what you want to do. So if we move on to the next stage, and again, this also depends on your age. This can start for standard stage 2 as young as 8, late as 13. I don't have some of the graphs I have on child development and the different ages that you can hit those different things. But, this down here kind of around age 11 on average for some of this stuff, age 12 ish, age 13 for, stage 4 roughly. By age 14, we're roughly in Tanner stage 5. But Tanner stage 2, normally we're talking around 11 years old. Again, give or take based on your child's puberty or the child's puberty. Again, you're also talking about height growth spurts and stuff happening in this period as well. That was girls. For boys, again, oh, what happened there? So for Tanner stage 1, again, no changes, no growth of the penis, no change in the testes, no pubic hair. That Tanner stage 2 for boys is testes increase in size, skin of the scrotum begins to redden. It will begin to grow itself. And Tanner stage 3, penis growth begins. Like I was mentioning earlier, this is where it's important for, if you're taking puberty blockers and your goal is eventually to transition into female, if you're wanting to have a vaginoplasty, will you have enough skin for the neovagina? You know, if you end up choosing that method, you may not be able to use that method if you don't get farther enough into puberty. One of the downsides of it. So, age 11, again, normally hitting all these things. By age 15, 16, we're normally in Tanner stage 5 for boys. Boys do develop a little bit slower as far as the onset of puberty and their progression through puberty. Boys will often have, you'll see more delayed puberty, and 11, 12, 13-year-old may still not have hit that point of puberty yet. So there are two goals justifying puberty suppressing hormones. We have to meet these. So the first one is the use gives the adolescent more time to explore the gender nonconformity and other developmental issue. And the use may facilitate transition by preventing the development of sex characteristics that are difficult or impossible to reverse if adolescents continue to pursue sex reassignment. We have to do the prescription and recommendation for the prescription of puberty blockers with these two goals in mind. If we don't meet those goals, then we should not be prescribing puberty blockers, right? So you can suppress it for a few years, decide to, undo it by just stopping it and going through natural puberty. Or you may decide to start taking the hormone replacement therapy for your identified gender. So for puberty suppressing hormones, this is us going from, just social to that first stage, fully reversible. We need to demonstrate these criteria. So these right here are the important things in determining whether or not we want to do puberty suppressing hormones. Again, these are the standards of care outlined by the World Professional Alliance for Transgender Health, or Association. I always mess up Association Alliance. So the first one is the adolescent has demonstrated a long lasting and intense pattern of gender nonconformity or gender dysphoria, whether it has been suppressed or expressed. So even if they have yet to like start social transition or any of that, they are still, outwardly having issues. They are outwardly struggling with it. Give me 1 second. I need to take a brief phone. Okay, I am back. So I'm going to finish up this section here. Then I do have to go. And what I might do is either resume later or resume another day the discussion on the Arkansas bill. So let me see if I can burn through the rest of this real quick. So let me just make sure one thing before I begin the rest of it. So, like I said, criteria one for puberty suppressing hormones. The next one is the dysphoria emerged or worsened with the onset of puberty. So even if they were suppressing their dysphoria and they weren't outwardly showing it, they still struggle with it from criteria one. And criteria two, they actual onset of puberty is making it worse, or it emerged with the onset of puberty. So that's important. Number three, any coexisting psychological, medical, or social problems that could interfere with treatment. So that may compromise treatment adherence, for example, have been addressed, such as the adolescent situation and functioning are stable enough to start treatment. So if the child is not in a situation where they're able to take the medications on a regular basis, either on their own or with assistance, that's not in a situation where they can deal with it readily. They are struggling with it. They are not ready. Or if their depression isn't managed to some degree, their anxiety isn't managed to some degree, they are suicidal. They are getting to the point of being suicidal. We're not ready to start puberty blockers. We need to address that. We can't be somewhat getting on the edge of feeling suicidal and then be prescribing puberty blockers, period. So we have to meet that criteria first. And then the adolescent has to give informed consent, particularly when the adolescent has not reached the age of medical consent. The parents and caretakers of the or guardians of that child have to consent to the treatment and are involved in supporting the adolescent throughout the treatment process. As I said earlier, medical treatment age of consent is normally somewhere between 14 and 18. A lot of the numbers I was seeing when I was skimming it was around 16ish, 14 to 16ish. Some again were different. Some, if you were emancipated, you were good to go as well. So call it 14, 16. You're still needing parental involvement if you want puberty blockers before then. Period. Now, as to whether one or both parents consent to that, that's a custody thing. If you're not married, if you're divorced, if you're split up, if you don't have equal custody, you both have to consent. One parent cannot consent. But if one parent has majority or full custody, they do get to make the medical decisions. They are the medical decision maker for the child. That is where you'll see cases that come up in the news where someone doesn't get the ability to say, no, I don't want my child to do this, or no, my child shouldn't be getting this treatment. That's why those become an issue. That doesn't mean the standards of care aren't being followed. That means that that parent isn't involving the other parent in the treatment of their child's dysphoria. That parent needs to be theoretically working with the second parent. Even if there's disagreement, they should be keeping them in the loop. You know, if you come across this, it doesn't mean that they're not following the guidelines. Now that may exist, that may happen. I have seen some cases of that, but in general. So when we talk about puberty suppression, we're talking about different types of medication for different, for the different genders and how they interact. They stop the production of estrogen, they stop the production of testosterone and progesterone. You're also talking about other ways to introduce that, stoppage of the puberty, stoppage of the continued masculization or feminization of different parts of the body. So the development needs to be carefully monitored by a pediatric endocrinologist during the process. So at the start, normally you're getting reevaluated every couple months, every 2 to 3 months, to make sure. And this you'll see with hormone suppressing, or not hormone suppressing, hormone therapy. You're getting reassessed every couple months or every 2 to 3 months to make sure your dosage is right, to make sure it's not too high or it's not too low, or that you're within the goal and guidelines you should be. So for puberty blockers, is it reducing the level of male or female hormones in the body to the level that we're looking for, that we're aiming for, with suppressing the puberty? That's the goal, right? So this is not necessarily a positive or negative act. Neither puberty suppression nor allowing puberty to occur is a neutral act. On one hand, functioning later in life can be compromised by development of irregular or irreversible secondary sex characteristics during puberty and by years spent experiencing intense gender dysphoria. On the other hand, concerns about negative side effects of puberty blockers on things like bone development, height. These approaches have shown promising long-term results, or promising effects. The long-term effects can only be determined when the earliest treated patients reach the appropriate age. So we're probably around the timeline where we may start seeing those long-term effects. It's hard to say. On to partially reversible, this is where we talk about hormone therapy. Adolescents may be eligible to begin feminizing and masculizing hormone therapy, preferably with parental consent. In many countries and states, 16 years old are legal adults for medical decision making and don't require parental consent. Ideally, treatment decisions should be made among the adolescent, family, and treatment team. The goal is to work together as a team, myself included, the doctor, the endocrinologist, everyone, in the end goal of treating all these things, to getting the client, the patient, where they need. So the regimen for hormone therapy is different for dysphoric adolescents than dysphoric adults. You have to take into account developmental stages for somatic, emotional, and mental development, where they are as far as their progress in adolescence with that, and the effects that any given dosage will have on that. Talking about irreversible interventions, genital surgery. So genital surgery should not be carried out until patients reach the legal age of majority in a given country or area, so like a state, and patients have lived continuously for at least 12 months in the gender role that is congruent with their gender identity. So with the standards of care, again, outlined by WPATH, which is basically the international setting of standards for this stuff, you need to be the legal age of majority in your country. For the US, it's usually 18. Other countries may be different. The age threshold should be seen as the minimum criteria, but not an indication in and of itself for active intervention. So you need to at least reach the age of majority. But that doesn't mean you need to start and actually have surgery to activate and start these irreversible interventions. You can do chest surgery earlier in a female to male patient, but preferably ample time living in the desired gender role and after 1 year of testosterone treatment is necessary, or at least preferable. So you still need to live or undergo a year of testosterone treatment before you have your breast removal. This is to give you the experience and have that opportunity to do and live in your now masculine male gender, and to see the social adjustment and how you will fit in before you undergo such an irreversible procedure. Again, these can be adjusted a little bit depending on the situation, also depending on any state or local or federal guidances in your district or jurisdiction. Refusing any kind of medical intervention could, or refusing timely medical interventions might prolong gender dysphoria and contribute to an appearance that could provoke abuse and stigmatization. As the level of gender-related abuse is strongly associated with the degree of psychiatric distress during adolescence, withholding puberty suppression and subsequent feminizing or masculizing hormone therapy is not a neutral option for adolescents, right? So, as I was saying, I have to cut it a little bit short. I forgot about something that was on my schedule that had to happen today. I'm going to see if I can finish the other part of this stream later. I will see if I can let people know. Before then, I'll see if I can schedule it as well so people can see it. But I appreciate anyone who showed up here today. And, I know some people have different views on it. I know some people are very frustrated about some of this. I look forward to discussions and interactions with this. If you have thoughts or input and would like to participate in this discussion after I go through this, let me know. Leave a comment in the comment section. Hit me up on Discord. I will have a couple other social platforms up and running soon. You can also hit me up on as well. And I will bring you on and I will have no problem talking to you. Again, this is not therapy. This is not clinical advice, if I haven't prefaced that already or before. But again, my goal today was to explain the expectations and the standards set forth for treatment for these things. With that in mind, before I do the next stream, maybe give a review yourself of the standards of care. You can find them by searching for WPATH Standards of Care V7, and you'll find them very easily on Google. You can also search for HB1576 from Arkansas and find the text as well. Give it a read through. Compare the two documents. Look at different definitions. Look at different expectations. Is the standards of care reaching too far? Did HB 1576 go too far? Did they maybe prevent people from having access to treatment they may actually need to prevent a worsening issue? These are all factors to consider. So I want to thank everybody for their time today. I appreciate everyone who showed up. I appreciate any comments in chat today, both good and bad. I always appreciate criticism. I always appreciate people who run counter to my own views. It's how I grow and develop, not only personally, but professionally. So take care. I hope to give part B to this stream later today. Like I said, I will do my best to update everyone when it happens. Have a great day, and thank you for spending your time here today.